Hi, my name is Maria Zambrana. I go to the University of Dallas, and this is my presentation for Dr. William Cody's microbiology class, and I am presenting on tuberculosis. So the name of tuberculosis is actually Mycobacterium tuberculosis, and a little bit about the um, taxonomy of TB is that it belongs in the kingdom of bacteria. And it has the subkingdom of Posiobacteria, the phylum of Actinobacteria, the subclass of Actinobacteridae, order of Actinomycetidae, and the suborder of Coronabacteridae, family of Mycobacteriaceae, and the genus of Mycobacterium. So what's interesting about all that is that it actually falls in the same genus as leprosy. And something that I found interesting is that leprosy, a lot of the symptoms actually also are kind of share similar characteristics to those of tuberculosis. It's just that one is a little more external and one's a little more internal. So the internal one is tuberculosis. So the type of cell that it is a non-sporing and acid-fast positive. In terms of gram-negative and gram-positive, there isn't really a clear difference there, because since it's acid fast, it's kind of hard to tell, because sometimes when you stain it, it'll either go purple or it'll go pink, but you can't really necessarily tell. But the acid fast positive, that means that it has a waxy coating of mycolic acid present on the outside of the cell surface. So that does two things for the cell. The first is that the resistance to stain, but the second is that it also is very helpful for the cell in terms of its virulence, so it greatly increases its virulence factor. The shape of the cell is bacilli, so it's a rod. The oxygen requirements are aerobic, which later on, when I explain the symptoms, it actually makes a lot of sense, because the disease occurs mostly in your lungs, and that's where there's a lot of oxygen. And transmission is airborne. So you can contract the disease or the infection through respiratory droplets. So from your sputum of an infected patient that's how you can get the disease. And it is non-modal. In terms of a little history, a little lesson is that TB has actually been around for a really long time. So this was a quote that I took from the NIH in 2013. Tuberculosis is one of the ancient and deadliest diseases of mankind. This is very true. The evidence of MTB, which is short for Mycobacterium tuberculosis, is present dating 70, like all the way back 70,000 years ago in Africa. And what's interesting is that it's actually, tuberculosis is one of the first and the most studied of infectious diseases. But considering how long this disease has been around and how recent all the discoveries has been, is actually kind of shocking. So Robert Koch is the one who discovered the cause of tuberculosis later, which he called tuberculin, which is just another way of saying tuberculosis bacilli, like a rod shape. And that was in 1882. He received the Nobel Prize for that. But up until that point, the best treatment options for tuberculosis were just fresh air and rest, which really did not do much. And then in 1943, that's when the first streptomycin was isolated, which is kind of the first effective anti-tuberculosis agent. But again, that's 1943, when we're only in 2018. So some of the incidence and prevalence is that before the emergence of HIV and AIDS, TB was the deadliest infectious agent worldwide. So that means that TB is now only the second deadliest infectious agent worldwide, which is still, it's very serious. It kills 2 million people every year. There's an estimated 1/3 of the world population is infected with TB. Now, don't freak out. When you're infected, that doesn't mean that you are actually sick. It just means that your body has it. It's inside your body, but it's not active. Most of these cases are latent. That's what that means when it's in your body, but not active. And then It's mostly concentrated in areas like Asia and Africa. Um, this graph, I wanted to put it in there because I think it kind of shows like what happens like in the terms of like how high the death rate was, and then seeing how it decreases more and more once you get like more and more research done, and then seeing the spikes during the World War I and World War II. I found that interesting. um, a little bit about the pathogenesis of the disease is that generally goes through respiratory droplets. So from tuberculin, from an active TB patient, so someone coughs, and then the other person eventually they inhale it, and then it can easily pass through there to your alveoli, to your lungs. Now, multiple things happen once it gets through alveoli. So the first thing is that your innate immune response attacks it via macrophages. But if it gets by the macrophages, then it starts replicating and starts infecting other cells. And then that's when your adaptive immune response forms a granuloma around the infection. So what happens at that point is that it can become latent. So it can lie dormant in your body for years, and it could, spark up again later on, like if you're become immunocompromised. Or what can happen is once that granuloma forms, it can actually become an active TB because it can escape that immune response, that granuloma, in surrounding fat tissue. So if that happens, that means that at that point you have contracted tuberculosis, you have it actively in your body. So that's when you're going to start showing some symptoms. So the symptoms are, the telltale sign that I think everyone thinks of when they think of tuberculosis is coughing up blood. And usually that cough is going to last for 3 or more weeks. You have a lot of chest pain when you're breathing and when you're coughing. There's fatigue, fever, night sweats, and chills, and a loss of appetite, which makes sense. I think it's important to note, though, that you're not always going to have tuberculosis contracted in your lungs. You can also have it in an extrapulmonary TB, is also possible. So when left untreated, tuberculosis is most likely to be fatal, and it can also cause a lot of complications. So some of those complications can be like spinal pain, joint damage, meningitis, and heart disorders. But again, that's when it's left untreated. So who's at risk of getting it? You're at risk of getting it if you basically have anything that's going to lessen your immune response. So if you have AIDS or HIVs, if you use illegal drugs, or if you are around someone who has TB, or if you live with someone who has TB. And the risk is also higher when you're in regions such as Africa, Asia, Eastern Europe, Russia, Latin America, and the Caribbean islands. So the way that you test for TB is through Mantox skin test, which is, I think, the one that most of us has probably gotten. Is when you go and they kind of insert a little bit of tuberculin under your skin, and then 48 hours later you go back to the doctor's office and they check to see if a bump has arisen. So if you do have a bump, that means it is positive for TB infection. Again, that does not mean that you necessarily have active TB. They measure it based on the size and the redness of it. But those aren't necessarily very reliable, the skin tests. So there's also like blood tests and X-ray tests that you do. And since those skin tests have come about, there has been a lowering of the active TB because of the medicine that you take once you see that you have TB infection. But I'm going to talk more about that later. The diagnosis is done through the sputum examination and a chest X-ray, and then the medication is a recommended 4-drug regimen. So if you do have active TB, then you have to take multiple drugs at a time. And then later on, you narrow it down to 2 drugs after 2 months. And then that's 4 months that you're taking those drugs. So in terms of prevention of TB, if you're in one of those countries that's very active, then you have the BCG vaccination, which stands for Bacillus calmate-curin, which is generally given to children at those high-risk locations. This isn't a drug that is used commonly in the US because it's not found to be effective in adults. And the other thing that you do to prevent TB is just you go and get your TB test, and there isn't necessarily, not that from what I found, there isn't a limit on how many times you can get that test. It's just if you feel like you've been around someone, or if you know you've been around someone who has TB. And the most common tuberculosis drugs that are used are isoniazid, rimfampicin, ethobutyl, and pyrazimide. So yeah, if you have active, you take multiple of those drugs, and then if you have latent, you just take one of them. In terms of what the current situation looks like now, as you could imagine, the drug has shifted and has grown, or excuse me, not the drug, the strand, the MTB strand, has shifted and gotten a higher virulence factor, and all of that kind of shifts how we look at it now. So what we call that is an MDR, so it's a multi-drug resistant TB, and that's something that has occurred. There have been multiple outbreaks in the U.S. starting as early from the 1970s, and then even up until the 1990s. There have been sporadic outbreaks in the U.S. But unfortunately, what that has done is that as soon as tuberculosis is less active in like westernized countries, then it isn't as like it's not addressed as a problem in low-income countries or in third world countries. And so this graph that I have here, I took directly from the World Health Organization, and it kind of just gives you the numbers as to what's going on with the multi-drug resistant strains, and it's kind of alarming. But in terms of tuberculosis, most of the people in the US, you're going to be fine. Make sure you go get your skin tests. And yep, if you're in the sciences, maybe this is your calling, that you should go and research this and try to get, discover a cure for these multi-drug resistant TB. This is my video. Here are my references. If you guys have any questions, please let me know. I'll see you all Friday.